ICD, because medical diagnosis alone does not accurately predict disability. The framework is based on a biopsychosocial, that is the ICF model of functioning and disability. Incorporates the multifaceted relationship between a health condition, that's the disorders or the disease, and the interaction among body, that is whole person, and the social perspective. That is what is telling us that ICF, took into cognizance the biological aspect, that's the physical aspect of man, the psychological, that's the mental aspect, emotional, then the social aspect, how the individual interacts or relates with the people around. Then it considers the context, that is the environmental and personal factors that can serve as barriers to or facilitators of functioning and disability. That is not just the physical aspect, not just the psychological or the social, also the environment where the patient lives. All those things are put into cognizance when you're talking about ICF. We'll still talk more about that. It provides a common language and framework for describing the level of function of a patient within their unique environment, or in other words, the level of capacity. That is, the capacity has to do with the activity of the patient, and also the level of performance, that's the participation, as opposed to just classifying the person by their specific health condition. That has to do with the medical doctors. I remember one day I took my daughter to see a doctor in the eye clinic. While the doctor was, the resident doctor was doing the assessment, he asked one of the colleagues to help her check the ICD code for that condition that my daughter was going through. So they use because ICD, they are the ones that use that, and they use it in their clinic. So it's also expected that we, the physiotherapists, we should also use ICD code for while we are assessing our patients. We'll still come to that. The ICF is a framework to approach patient care that shift the conceptual emphasis away from negative connotations such as disability, and places focus on function and the positive ability of the individual at the patient's level rather than the system's level. So what is telling us that the ICF shift focus from just the negative aspect of the patient's condition, that the condition led to, that's the disability, the impairment. But it focuses on the positive, the ability of the patient. That's why these days, we don't call maybe people with disability, disabled people, or handicapped people. In fact, that word handicap is no longer in use. But that's why they are called people with disability. There is ability in these people. Physiotherapists, or they're not just physiotherapists, all the health professionals under medical rehabilitation, we need to not just seeing the disability in these individuals, but see the abilities in them, the things they are capable of doing. And even when we see those things they are not able to do, our duty is to bring them back to what they were doing even before the problem started. We don't have to see them the way the society sees them. That's why I said here that the positive ability of the individual at the patient's level, that level the patient is operating at, we are supposed to move from there. We'll still come to that. Move from there, see the things the patient can do at that level, and begin to work towards the patient being able to do the things he was not able to do, either by introducing some maybe assistive devices or other things that will enable the patient do to that, or other things that will bring in the ability of the patient to bear. Then rehabilitation is an important part of the universal health coverage, and is a key strategy for achieving Sustainable Development Goal 3 by 2030. Then the goal 3 of the Sustainable Development Goal says, that is goal 3 of it says, ensure healthy lives and promote well-being for all at all ages. That is health for all ages. And I thank God our registrar and the members of the board, they are really working towards our achieving this. All the health professionals under the medical rehabilitation to achieve this through rehabilitation, that health for all, universal health coverage by year 2030. Rehabilitation is defined as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with the environment. What is that telling us? It means if you call yourself a rehabilitation expert or rehabilitation professional, and whatever thing you're doing in the clinic does not gear towards this, there are 3 things here: optimizing functioning and reducing disability in individual. And another thing, you say with condition in interaction with the environment, integrating the patient or the individual into the society. If you have not achieved this, it means you are not working towards, rehabilitating the patient. All these things, whatever thing you're doing for a patient in the clinic, these 3 things must be there. You must optimize functioning. You must work towards reducing disability, and you must work towards integrating the patient into the environment. Patient going back to what he was doing before the problem started. As in, maybe the patient was a typist, maybe had an accident and is not able to use the hand. As a rehabilitation therapist or professional, your aim is to assist the patient or help the patient to go back into that profession, typing profession. All this should be your goal. It helps a child, adult, or older person to be as independent as possible in everyday activities, and enables participation in education, work, recreation, and meaningful life roles, such as taking care of self and others. That's what rehabilitation does. It helps the patient to become as independent as possible. That is when you can say that you have achieved your goal in the management of a patient as a rehabilitation professional. It does so by working with the person and their family to address underlying health conditions and their symptoms, modifying the environment to better suit their needs using assistive products, educating to strengthen self-management and adapting tasks so as to perform more safely and independently. All these things will have to be, if patient needs assistive device, provide for them. Let me say, for instance, a patient that an amputee, who told us that an amputee cannot lecture. An amputee can still, there are things the person can still do, even what he was doing before the problem started, or whatever thing that caused the amputation. All those things that I was doing before can be done. Patient can return back to all those things using assistive devices, maybe prosthetics, maybe using crutches. Our duty is to make sure that at the end of everything, the patient goes back to the former occupation or what the patient was doing before the problem started. These abilities may be physical, mental, or cognitive. That is thinking and learning, lost due to a disease or injury or as a side effect from medical treatment. It provides a framework to organize the information in a way that allows us to analyze and understand disability more effectively. It can be a useful tool in implementing community-based rehabilitation program. That's the ICF. The ICF framework is guided by the definition of disability and as being the outcome of an interaction between a person's health condition and the context in which the person lives. patient's condition. Yes, the patient has the problem has come. The patient is without some abilities. Your duty is to make sure at the end of the day, the patient returns back to what he was doing before. Looking at the environment, checking those things that are barriers, those things that are facilitators that can assist the patient to or bring out the abilities in the patient so that the patient will be able to enjoy his or her social life. The ICF can be used in assessing individuals, their communities, and environments to determine the factors that are creating the disabilities and provide structure for appropriate intervention. These are the things you can use ICF to do, as to use it to assess individuals. We're going to talk about that more. And also the environment, the community where the patient lives, because all those things are in ICF assessment. All those things have to be looked into to know the things you can apply, can bring in that will facilitate the patient's ability to function better and improve the quality of life of the patient. World Physiotherapy adopted a motion supporting the use of ICF in physiotherapy in 2003. 2003, that was when it was adopted by the World Physiotherapy. You can see we are really backward in this. It's up to 20-something years now. And we are still talking about how to use and for us to start using it for 20-something years. So it's a call for us to do the needful as from today in our clinic, to begin to use ICF to assess patients rather than what we've been doing, because we've been dwelling on impairments. Yes, it's good for us to work on the impairment. In fact, it's one of the concepts or components of ICF, but we have to progress from there to check other things. Also look at the environment and be sure that we integrate the patient back into the society. Because it's the doctors that are meant to dwell on impairment. When you are not, taking into cognizance the other things, are just dwelling on the impairments to manage and improve on the impairments. You are just like doing what the doctors are doing. If you call yourself a rehabilitation expert, you must go beyond that to make sure that every aspect of the patient, be social, be psychological, every aspect, how the patient was doing things, the way he was doing it, and the better way to even do them, even after the condition. Then the goal is to ensure, we're talking about the aim of ICF. The aim of ICF, the overall aim of ICF is to provide a unified and standard language and framework for the description of health and health-related states. ICF provides a common language. Like now, as I'm talking to you now, if we start using this ICF is ICF everywhere, in the United States, in Germany, in Canada, everywhere is the same thing. It's expected that if you assess a patient here, and maybe you want to refer the patient to maybe a hospital in United States, when somebody sees your assessment, should be able to understand it, because ICF is the same thing that is being used all over the world. So it provides a standard and a unified language and framework to describe the health and the health-related state of an individual. The goal is to ensure that individuals can live with disability without being handicapped. Like I said, that word handicap is no longer in use. It's no longer, we need to do everything to prevent this word, because there is an ability in every individual, no matter the state of health of that individual. There are things you can bring in so that the ability in that patient, so that the patient will come out, so that the patient will be able to function even at that state of health. The concepts of ICF, because of our time. Okay, let me just run through them before we now go to, because of our time, run through the main thing, well-being. It is a general concept that comprises the whole universe of domain of human life, including the physical, mental, social, and that make up what is considered to be having a good life. before you can say that somebody enjoys good quality of life. In fact, that everything about that person must be intact. That's the physical. You have to consider the physical aspect. You have to consider the mental. You have to consider that's the psychological, also the social, not just the physical, which most of the time we dwell on in our clinics. We don't even remember that, the psychological trauma, the condition of the patient is causing the patient, the social aspect of the patient. So it's expected as from today, we begin to consider all these things. Also, okay, all health condition is any change in or attitude of an individual state of health that may cause pain, suffering, or interference with daily life, which may be disease, disorder, injuries, trauma, or may even reflect other health-related states, such as pregnancy. Body function. Body function is the physiological functions of the body system, including the psychological functions. Body structures, the anatomical parts of the body, such as organs, limbs, and their components. All these things I'm talking about, they are important. They are the components of ICF. Then you talk about their impairments, that's the problems in the body function and the structure, such as significant deviation or loss. Activity, the execution of a task or action by an individual. Participation, involvement in a life situation. An activity limitation means difficulties an individual may have in executing activities. Participation restrictions, problems an individual may experience in involvement in life situations. All these are components of ICF and also or concepts of ICF too. Functioning is an umbrella. Okay, let's just go in. Okay, concepts of still under the concept of ICF, environmental factors. That's the physical, the social, and then attitudinal environment in which the people live and conduct their lives. These are either barriers or facilitators of the person's functioning. Then personal factors are the particular background of an individual's life and living, and comprise features of the individual that are not part of the health condition or health state, like age, marital status, the coping style of the patient. All these things are there, the culture of the patient. While we are assessing all these things, we have to really be put into cognizance. Then the type of environment, how physical environment. Physical environment, the natural and built surroundings in which people live and interact. That's the surrounding of the the surroundings where the patient or the individual lives and they interact. Example, buildings, how the building is. Are there things that will facilitate the patients even in the building? Let's say, for instance, a patient that is living upstairs and has maybe quadriplegia or is using wheelchair, it's expected that the patient should relocate from upstairs to ground floor, because so that it will be easier for the person. And another thing, maybe a building without a ramp or a elevator. All these things are necessary. If they are not there, they are barriers. We need to put in place the things that will facilitate the patient wherever he or she lives. Examples, building roads, transportation, how's the road? Our roads here in Nigeria is not really disability friendly because of the potholes. Maybe somebody that is using wheelchair will not be able to apply some of our roads here. There's transportation systems, outside the country, their vehicles are disability friendly because they have things that will enable the patient or the individual to enter the vehicle easily. We have the schools, the hospitals, climate, terrain, air quality, assistive devices, accessibility of facility like a ramp, as I said, and the elevators. You have the social environment. That's the network of people, institutions, and social structures that influence individual behavior and participation. All these things will have to be put into place. You have to consider them while you are assessing your patient. Example, family, friends. Does the person have people around that will assist the person? The peers, the community groups? Is the person, how are they seeing the patient or the individual with disability? Are they discriminating? Are they discriminating? Are they denying them some things? You know, like somebody that that facilitated last week was talking about disability, you know, like the government have put up maybe 5% when they're doing employment for people with disability. That means that the government, they are now becoming disability friendly. Then attitudinal environment, the beliefs, values, stereotypes, and attitudes held by individuals and society towards others. That's also the discrimination we are talking about. You know, some people discriminate these people with disability, the way people see them. Some people will not want to marry them. You know, all these things, the way the mindset of people towards the people living with disability can create a negative attitudinal environment for them. Whether the positive one is when they are accepted, they are respected, they are encouraged, they are you know, the inclusivity. That is inclusive in both in education, in everything, in employment. The negative is the stigma, discrimination, and lack of awareness. Then the predisposing factors is that can lead to disability. One is medical condition, injuries, developmental or genetic factors. Then age, some are age-related. You know, aging can bring about physical or cognitive challenges that may lead to disability in older adults. The models of disability, we have two main models. We have the medical and the social model. The medical model of disability views disability as a result of individual's impairment or health condition. It focuses on diagnosing and treating the person's medical condition to improve their functioning. Disability is seen as a problem within the individual, and the goal is often to fix or to cure the person. Then the social model of disability emphasizes the role of society in creating barriers for people with disabilities. You know, the way the society see these people can hide the ability in them. But if they are not being discriminated, if there is inclusiveness, even in the schools, everywhere, their people are not discriminating against them, you find out that it will make them to bring out those things, the abilities in them. They'll be able to function properly. I remember one of when I was a student, in fact, she was 2 years above me. You know, she has polio. And when she graduated, she started working, you know, teaching in UNEC. And from there, she traveled outside the country. She uses her crutches, elbow crutches. And now she's a professor. You know, because I remember that time we were all, you know, we were rallying around her. You know, we're not seeing her. She was in my fellowship too. We are not seeing her as somebody that is disabled at all. You know, we're interacting, we're friends. Now the ability in her has come out. When we see people that they were physically challenged, it's not a time for us to begin to discriminate, because all these things, they affect them negatively. But when you see them as other people maybe that are able, that's normal, you find out that it will help them to bring out that the potentials in them rather than discriminating them. He said it argues that disability is not solely a medical issue, but a social one, as societal attitude and physical environments can disable individuals. In fact, it's even worse than the physical environment. He said the focus is on removing these barriers, promoting inclusion, and ensuring equal access opportunities. It will help these people. Then the components of ICF. ICF has two main components, which are further divided into categories. You have the functioning, that is made up of the body functions, body structures. You also have the activities and then participation. Body functioning has to do with the physiological function of the person, such as the sensory, motor, and mental function. You have the body structure that has to do with the anatomical part of the person, like the organs, the limbs. Have activities and participation. So this category assesses the individual's ability to perform tasks, and participation, the ability to live, the ability of the person to participate in life situation. Then the contextual factor that has to do with the environmental factor. And also we have talked about that. And also the personal factor. We have also talked about the personal factor. Then this is the diagram for ICF. You have the health condition, have the body function, just like we have talked about under the concept and the components. You have the activities, you have the participation, you have the environment and the personal factors. Then the benefits of ICF to rehabilitation. One is a holistic assessment. ICF will enable one to, it provides a comprehensive and holistic framework for assessing patients. It goes beyond just focusing on the physical impairments and considers the broader aspect of an individual's life, including their participation in society and the impact of environmental and the personal factor. It goes beyond the impairment to look into the activities of the patient and also how the environment of the patient, how the patient participates in the environment. Another is a common language, provides a common language and standardized terminology for healthcare professionals, making it easier to communicate and collaborate with other members of the team. Like, let's say, for instance, when we are seeing, maybe as a physiotherapist, if you have knowledge of ICF, it's expected that when you put down the maybe document on the folder, another health professional like a speech therapist or occupational therapist or even the medical doctor sees it, should be able to know what you did. So it brings it showcases or it unifies the health professionals. It helps for collaboration and the interdisciplinary teamwork. Then goal setting. The ICF assists in setting meaningful and patient-centered goals. In fact, in ICF is patient-centered. What you're doing does, in fact, whatever thing you're doing, like I use somebody that is a typist that has an accident and has problem with the hand. And the typist, as you're managing the patient, it's not after what you're doing, all these muscle strengthening and everything you're doing. What the typist is after is everything you're doing at the end of the day, we should be able to type again. So that's the goal of the patient. You marry it with your own goal in order for when the two goals marries together, at the end of the day, you come out with a better outcome. Then treatment planning, it aids in the development of personalized treatment plans. It guides rehabilitation specialists in selecting interventions that target the identified impairments, activity limitations, and participation restrictions. Then outcome measurement. It provides a structured way to measure and monitor outcomes. This allows for the evaluation of the effectiveness of intervention over time and the adjustment of treatment plan as needed. We'll still come to that. Then patient-centered care, as you also talked about, the ICF encourages a patient-centered approach. Rehabilitation specialists can better understand the individual needs and preferences of patients, promoting more personalized and then empathetic care, patient-centered care. Then the quality of life. The ICF is a valuable tool in rehabilitation that enables a more comprehensive, patient-centered, and evidence-based approach to assessment, treatment, and rehabilitation. It enhances the quality of care and help improve the lives of individuals with physical impairments and disability. Then monitoring and evaluation. The impact can only be measured if an initial assessment is undertaken and follow-up assessments are done during the course of the intervention program. Then motivation for policy. This creates inclusive employment practices, inclusive education, ensure the implementation of building regulations for accessibility, develop a transport system that is accessible and cost-effective, and so on. So ICF can be used to make policies for people with disability. Then the coding, ICF coding. Every domain and subdomain in the ICF has a specific code. These codes are a summary way of recording the domains described. Like in ICF, there are codings, but we don't need to bog our heads with the codes because they are all in the internet. And if you go to our ICF website, you can also see it. So it's not for you to begin to cram the codes. Every domain of health conditions, they all have their codes. They all have their codes. So what you just need to just go to the internet, get the code. Example, instead of recording moderate difficult in walking, but severe difficulty walking in usual environments, one can use the code for walking plus the qualifiers for activity and participation, giving D450, 32. Okay, let's just stop at D450. D450 is the coding for walking, because we are talking of coding now. We'll still come to qualifier. The coding for walking under walking domain is D450. If you go to the internet, you will see it there, D450 as the code for walking. Then, we talked about body functioning, which is is made up of the physiological aspect, then and the psychological aspect of the individual. If you want to write the coding for body functioning, is B. You start with B. Then for body structure, which is the anatomy, is S. Then activities and participation is D. Environment is E. You said the prefix D denotes the domain. Oh, I've talked about that one. So we still come to that. Then the ICF qualifier. The International Classification of Functioning, Disability and Health uses qualifiers to provide more detailed information about an individual's functioning and disability in specific areas. Qualifiers used to denote the level of functioning and health or the severity of the problem. It's used to denote the severity of the problem and the level of the functioning. The percentages in ICF qualifiers are there to help standardize how much of a problem exists in the individual. There are ranges of severity, and they represent the extent of impairments that is under body functioning and the body structure. Then difficulty under the activity and participation. Then barriers under environment. The percentages are a way to give a more quantifiable sense of the severity. Qualifiers are numeric or with signs, that is when you want to write a qualifier for environment, use sign for facilitators. If when you are assessing and there are things in the environment of the individual that facilitate the patient to function better, then you put plus. You say qualifiers are numeric values that are appended to those codes. That is the codes, like example I gave, D450 for walking, to indicate how severe a problem is or how much an environmental factor acts as a barrier or facilitator. Okay, look at how to write the qualifiers. 0. When there is like 0 to you target 0 or you write 0. Let's say that D450. If there is no problem, then you write D450.0. It means there is no problem. The person has no difficulty or impairment. That is impairment if you're talking about body structure or body function. But if you're talking about activity and participation, then there is no difficulty in performing activities or in participation. Then 1, that is 1 is from 5% to 24%. Okay, let me just explain this. What that 5% to 24%? Let's say, for instance, if the time the patient presented to you, you ask the patient, when did this problem start? The patient says, a month ago. That 1 month is 30 days. 30 days, 25% of 20 or 24% of 20 days, or let's say 25% of 20 should be 7.5 days. If the problem has been there for 7.5 days, it means it's mild. There's mild problem. And also, another thing, you also have to ask the patient if the person has a small or slight difficulty, noticeable but not a major limitation. There is difficulty, but it's small. It's not a major limitation. The person can still do what he was doing, but there is a limitation, but it's not a major one. It's not noticeable. Then you target mild problem. If it's impairment, that is body structure or body function, it means mild impairment. If it's activity or participation, it means it's mild difficulty in participation or in performing activity. So also the other ones too, from 50 to 95% means severe problems. That is, the person has a great deal of difficulty functioning in a very limited and only partly possible. That is 50 to 95. If it's 50, means maybe 50 to 95, maybe more than half of the 30 days. If it's more than half of the 30 days, then you'll target a severe problem. Then 95 to 100% means a complete problem. The person is unable to perform that activity or the function, and the function is entirely impaired. The patient cannot do anything, is entirely impaired. Then you target 4. That's complete problem. Then you target 8 when there is a missing data or missing information or insufficient information to specify the severity of the impairment. You target 9 when it's not applicable, like the example I gave here for maybe when you talk, maybe you're managing a patient, a 6-year-old patient, and a 6-year-old patient should not be menstruating, or maybe a menopausal patient, and there's something that has to do with menopause, it has to do with menstruation. You don't need to start asking the person about that, because the person is no longer menstruating, which means it's not applicable. Then these are examples of a body function. Like this code, this one is under the domain of the sensation of pain. Sensation of pain, which is under body function. That's why they use B. Then the coding is 280. Like if you go to internet now and type there, the ICF coding for sensation of pain, what you see there is B280. Then 2 means there is moderate problem. So this is how it is written, the ICF qualifier. This is how you bring it into the ICF coding. This is for body structure. This is for body structure. So this is for walking. We've talked about that of walking too. Okay, this for environment. 0. You know, environment, you have the barriers, you have the facilitators. 0 for no barriers, 1 for mild barriers, moderate barriers, that is 2. 3, severe barriers. 4, complete barriers. Then the same thing for facilitators, but in facilitators you put a plus. That's what distinguishes it from the barriers. Okay, like this, the example 4, the code. This is a barrier. That's why it's E150. You know, I told you that E represents environment, just like B is body function and body function. E represents environment in the coding. Then this, look at the this alternative facilitator, +2 is added to the coding. Then assessment using ICF. Assessment using ICF, just our normal assessment in the clinic. When we want to assess a patient, you first of all get consent from the patient or the caregiver, if it's a child, or the patient has a cognitive problem and will not be able to give consent. Then you get from the caregiver, take your demographic data, referral, diagnosis, maybe from the doctors. Then we take our subjective assessments, our normal assessment. I won't go into that with what we've been doing. Objective assessments, general observation, we'll take our vital signs. Then remember I said our assessment and management must be in ICF, must be patient-centered. You need to know patients' ideas, the major concern and the expectations. You have to work towards achieving that goal for the patient. Then assessment using PRL and the quadrants. But I'm not dwelling on this because I know somebody else will talk about this package of intervention in rehabilitation. Then the next thing you do is you get the functional level of activity of the patient. At the level, when the patient presents, what's the highest functional level of the patient? Because you have to go from there. You have to go from there. ICF assessments with ICF coding. First of all, you have to get the ICD code. That is remember I said it's the doctors that usually use that. But when you are assessing, you also have to get the ICD code. You know, from that diagram I showed us, when you want to assess, you assess using that diagram. ICD code is the first thing, the health condition. If it's stroke, you go to internet and download. ICD code and ICF code, they are two different things. Remember I said ICD has to do with the health condition, but ICF has to do with the functional status. Then ICD code, they are all there in the internet. I think they have the version 11 now. Then after getting the ICD code for the health condition, then you assess the impairment. The impairment has to do, like I said, the body function. That's the physiology. Let me say, for instance, a patient that has a spinal cord injury. You assess the motor, you assess the sensation, all those things. Then which part affected? All those, that's the structure, the anatomical structure affected. You have to put it down under impairment. Then activity limitation, the impairment, let's say for instance, patient has there is spasticity. That spasticity, what are the things is preventing the patient? What activity is preventing the patient from doing? If the patient cannot walk because of the spasticity, you begin to, and before then, as you're managing the impairment, you have to also prevent further activity limitation. What are the things you do in order to prevent further activity limitation? Or you have to put them there under the impairment column. As you are assessing, look at also what are the things you are going to use to manage the impairment you have discovered. Then what are the things you are going to use to prevent further, because automatically the impairment will hinder activity. As you're managing the impairment, you also be into prevention, prevent further activity limitation. Then you assess the activities the patient will not be able to do. Then what are the things you are going to do in order to prevent, because activity limitation will prevent participation. It will prevent the patient from participating, which means you need to prevent further participation restrictions. What are the things you do? Then you have to assess and also plan your treatment on how to improve the activities of the patient and how to prevent those activity limitations from preventing the patient from participating. Then when you are talking about participation, participation has to do with the environment. You also have to check the environment to know the environment the patient is living, whether in the school, in the home. These patients cannot walk. What are the things you are going to do? Bring in maybe a quadriplegic patient or paraplegic patient. This patient is paraplegic. What are the things you need to introduce in order to facilitate movement? You bring in wheelchair. Yes, wheelchair is there. Can the patient use the wheelchair in the environment? You check the environment. Is there need for it to provide ramp for the patient to have access to the house? Then personal factor has to also do with the patient, the people, the characteristics of the patient, the background of the patient, the age, the people living around the patient. Let's say, for instance, if let's say a patient with a paraplegia, an adult with paraplegia that is married, of course, the patient will be able to participate more because there's somebody on ground that will assist, maybe wheeling help him to wheel the wheelchair or help in some activities, rather than the person is living alone without a help. So these are the things you have to assess. I say I'm dwelling more on this is the problem list. List out the problems, the missing components, the underlying reasons, indicators, and the outcome measures. Then the diagnosis using ICF. Let's say a patient with quadriplegia. You want to write your diagnosis. You can write it this way: impairment in motor function, limitations in mobility, and restrictions in occupation. If the patient has been maybe had an occupation before the problem, had the problem, then it means the patient will not be able to go back to the what he was doing before, which means there's restriction in occupation, secondary to spinal cord injury. Then you plan your treatment to improve the body functioning and the structure, the activities, and participation, and all the environment. Remember, I talked about the prevention. Then in conclusion, using ICF framework, professionals, rehabilitation specialists, and caregivers can collaboratively assess the functional status of individuals with disabilities, considering not only their impairments, but also the environmental and personal factors that affect their daily lives. This holistic approach can guide the development of personalized rehabilitation and support plans, aiming to maximize the individual's participation and quality of life after an injury or illness. It provides relevant information for individual interventions, program planning, community and policy development, and evaluation. These are my references. Thank you for listening.
Okay, thank you so much, Ma. Thank you. That was quite an expository class, but the thing here is that some of us we actually make use of ICF in our clinics without knowing that we are making use of ICF. So having this class has actually opened our eyes to see other areas of it that we should give attention to. That's the environment and also the attitudinal action of people towards response of people to our patients, and not allowing people to call our patients handicap. Yeah, I think we should start that as physiotherapists, because we really need to build the confidence of our patients for them to really see that even with their disability, they are still functional, they can still be functional in their society. So thank you so much, Ma, for this class. So it's time for questions. We'll just take 4 questions. So I'll select the 4 persons like that to just give us a wave for questions. So okay, I can see 2 hands up already. All right, so I will unmute you to ask your question. Thank you.
Hello, good evening, Ma.
Good evening.
Thank you very much for this wonderful presentation. Please, I'm lost during the assessment proper using ICF, those codes and the rest of them. So in a nutshell, what I'm trying to ask here is, can there be a specific outcome measure that comprised all this step-by-step, what do you call it, the step-by-step of how we are going to make assessment using this ICF? Thank you very much, Ma.
I don't understand. I didn't get you. Excuse me. I said I didn't get your question.
Okay, Ma, if I can rephrase what he said, he's trying to ask if there's something like an outcome measure where we can get all these codes like combined together that one can easily assess. So I think that's just his question. But if that's not it, please, sir, can you repeat your question, Mr. Suleiman?
If that is his question,
Exactly, that's my question. I was muted, that's why. So I'm just as you rightly, the moderator rightly said, that's my question specifically.
okay, just like I said, like all these codes, I said they are in the internet. That I don't need to bug your head in cramming to know all those codes. If, let's say, for instance, walking, if you type ICF, a code for walking, they will just bring it out for you. Or you go to their website, D450, it will just come out there for you. But in your assessment, you now begin to assess. For you to now write the qualifier, I said the qualifier is just like an outcome measure you use to check the level or the severity of the problem. And that's where you now use the ICF qualifier. You use 0 when there is no problem. You use 1 when there is mild problem. 2, when there is moderate. Then 3, when there is severe. Then 4 is when there is complete problem. Both in the impairment, that is the body functioning and the body structures, in the activity and the participation, and also in the environment. Maybe when I send the slide, you'll be able to know exactly the things that entails in 0. Like when there is no difficulty, it means there is no the patient that has no problem, there is no difficulty, maybe movement, and there is no impairment in body function. For 1, like I said, it means the person has a small or slight difficulty, or noticeable but not a major limitation. Then you target mild, and the code, and what the code you use there is 1. Then moderate is 2. It means the person has a clear difficulty that interferes with performance, but they can still manage with efforts and support. Then you target 2, which is moderate problem. For impairment, if it's for impairment, maybe you're assessing for impairment under body structure, body function, it means moderate impairment. But if it's activity, or there is activity limitation or participation restriction, it means moderate difficulty. Just like that, you assess it to 4. That is a complete problem. Maybe when I send the slide, you'll be able to memorize it better and use it when you're assessing your patient. Has that answered your question, please?
Mr. Suleiman, your question be answered. I can't even.
I can't hear the moderator.
Okay. Good evening, ma.
Good evening.
Thank you so much, ma, for the wonderful presentation. Thank you. It was very detailed and comprehensive, and I see the value in the ICF model itself, but I am struggling to understand something. It's in relation to the ICF coding. I understand the need for the ICF model itself, but what I'm struggling to understand is the need for the coding. If all the details of the patient's condition and state.
Sharon, please hold on. Sharon, Dr. Olowo, please hold on.
Yes, sir.
Can you
Okay,
hear
sir.
me? Can
Yes,
you hear
sir.
me?
Yes,
Sorry,
sir.
just want to get something clear. That last question, Dr. Heike didn't explain what the guy is saying. So, and I don't want it to be skipped because I might get involved in something. I have some other meeting that I'm attending by this. Now, the thing is, what the guy is actually asking is to link ICF with the outcome measures. What Dr. Heike explained is, sorry, let me first thank Dr. Heike for a beautiful presentation. This is more detailed than the last the last RCF class. And this is what I advise people, that this present class gets better than the previous one, and people should take it because there's more to learn. If I knew that it's going to be this detailed, I will have advised that they should combine the last RCF and this class so that they can take this together. Anyway, ICF and outcome measure. Now, when you look at what Dr. Heike has presented, you can put a lot of things into some major category of impairment, activity, limitation, and participation restriction. So what the guy is asking now is that how do I use ICF? The coding is a structured thing, and just to, instead of using lots of words, Once I put those code in, I already know I'm talking about body parts. I'm talking about in relation to the environment. So if I see B and I see E attached, I know, okay, I'm looking at environment and the body. But that is not the outcome measure. What is now asking is that how do I apply outcome measure? You don't need, I hope this person is listening to me. You don't need to go and look for another or develop any outcome measure to use in conjunction with the ICF. Every outcome measure that we use in rehabilitation, 99% of them are based on the ICF. Remember, the ICF is a standard that was created by teams of people all over the world before we come to unity of these terminologies, which is universal. And everything has been taken into consideration. There's nothing that affects the human body that cannot be put into this broad aspect. Now, if you are looking at the environment and this person's ability to be able to go to church or go to mosque or being able to do basic things within the environment. Now you are looking at participation restrictions, right? So all the outcome measure you will use at this point is to focus on participation restriction inside the environment. And there are a lot of outcome measures. Most of it is centered around quality of life. So when you work and you are researching on things that has to do with the environment, the outcome measure you should look for basically is quality of life measure. You don't know one. I hope that is clear. And so you don't need to go and develop, or there are some outcomes that are already that have to be developed to be used with the ICF. The ICF is inclusive, right? So if you are looking at impairment, for instance, spasticity measure is impairment measure. Has nothing to do with activity, right? So when you look at balance scales and all that, all those are basically, even surgery is an impairment measure, or the outcome of any intervention that sees to maybe the tendon release, spasticity measure, casting, prosthesis, and all that. Basically, these are working on the impairment measure. So anything that has to do with those three, remember, you are measuring the impairment. Here is where we got it all wrong. When you look at a lot of our articles, you are going to see they will use spasticity measure without relevant to the ICF. Without reference to the ICF. So it gives the impression that because I have managed spasticity, automatically I improve the quality of life or I improve the participation restriction because it wasn't put under the ICF. And this is one of the ways you can know if a research is doctored and it's not true, because there's no way you can be measuring an impairment or use an outcome measure that I know on the scale is measuring the degree of impairment. And you are now reporting improvement in quality of life, participation restrictions, and all that, which all evidence shows you cannot be managing an impairment and say that you automatically get result in quality of life. You have to treat quality of life. The fact that a surgeon do amputation doesn't necessarily lead to the quality of life of the patient. Quality of life of the patient have to be treated. So I hope I'm able to explain that. Outcome measures are there, but you have to know this outcome measure. What are they measuring? Are they measuring impairment? Are they measuring activity limitations? Are they measuring quality of life? But a lot of research that I've seen, they misuse those outcome measures. So people can place them. Because you will see they are reporting things about impairment and they are mentioning improvement in quality of life. Put it under the ICF, you will know this is a doctored report. Something else produced that result, not that research that produced that result that wasn't discussed about. Thank you. Sharon, please go ahead.
Thank you for your contribution.
Sorry, you can ask your question, please. You've been unmuted.
Thank you so much. I think you already answered my question, so thank you, sir.
Okay, please,
evening.
Mr. Lua Somidot, you can ask your question.
All right, thank you. Good evening, everyone. Thank you all for the presentation. My network was phasing me out, so I'm not sure if you spoke about this, but I just wanted to be clear if, but I think Dr. Adorin even mentioned that when we are documenting, so we are to use the codes. I'm guessing then maybe like everyone should readily have a copy of the entire document so that if people need to cross-reference and know exactly what we are talking about. But so again, this is my question. For different things, since body functions has its own codes, the contextual factors have their own codes and everything. Does that mean that for a particular patient, we could have up to 5 codings, and then if that's possible, even in body limitations, is it possible to also document multiple codes, or there is a restriction in how much we can put?
There is no restriction. Thank you for that question. There is no restriction. As you're assessing your patient, whatever thing you see, you document. And every problem you're able to get, or maybe you see as you're assessing a patient, every of them, they have their domains. They are all there in the website. Or if you don't want to go to the website, you can just type, like I said, in the internet, they're all there. ICF, maybe the patient cannot walk. There you type ICF coding for walking. It will come out there. But it's always good, in order for you to, like I said, get the highest functional level of the patient. Get the highest functional level of the patient, because that is where you're going to start. A patient that's, like the example I gave, a patient that is paraplegic and is there just lying down. Of course, when you're assessing with ICF, when you come to activity limitation, is the activity limitation there is mobility. Walking, no, you won't talk about walking now, mobility. Then if you go to ICF coding, you get coding for mobility. You get more coding for mobility, because you are going to take it from there. What are the things you are going to introduce in order for the patient to be able to move about? You bring in wheelchair. Then with this wheelchair, can also help the patient to participate. It can help the patient as well. But let me use this as an example. There was one patient that we had, one spinal cord injury patient that we had. We started managing, and not in my, okay, I was seeing the patient in the ICU because the patient was fighting with the brother, and the brother pushed her down and she hit her cervical at the edge of the bed and got the hardware quadriplegia. When the patient was rushed to the ICU, I was managing the patient when she was in the ICU. Later, the patient was transferred to the neurosurgical ward. Then our adult patients, adult physiotherapist started managing the patient. I think that I saw the patient, she was holding a phone. So I asked her whether she can write. She said she can write. I was like, because she was in first year university. So I called the father. I was like, if she can write, why not her go back to school? But the only thing now is that she won't go back to Nsukka because Nsukka is far. she maybe get a school in Enugu where, you know, somebody, maybe she may be coming from home, so that she also combine it with her management in our center. Maybe somebody will take her to school and bring her back. You know, in doing that, you know, I was trying to help the patient to participate. She was in school before. You know, we need something. Now she's on wheelchair. She needs something that will assist her to go back to school. Now we have rehabilitated the patient that she can now walk. She can now write, sorry. So there was nothing to prevent her from going back to school. And today, she has gone back to school because they found one private university in Enugu. The only thing that she has to change the course, she has to start from first year. He said, you can continue, you know, go on with your life. You can still become what God wants you to be. That this should not just keep her there. I advised her. That is what it means. Taking the person back to what he or she was doing before. Then in the mobility, when you're taking the code, for that patient now, the code, all the things you assess, you have to write them there. The codings for everything, what the patient is not able to do. Look at the domain and put it down, because all these things will guide you as you're managing the patient. Because as you are assessing, you are also planning your management. This patient cannot do this because of this. As you're managing the impairments, what are the activities the patient that is not able to do because of this impairment? You start doing things that will help the patient to be able to do those things. What are the patient is not able to do? That is the participation now, the way that he was doing before. You begin to work towards that. I don't know if I've answered your question. Hello, I don't know whether I've answered your question.
Yes, well, thank you.
All right.
Okay, Mr. Ibrahim, you can ask your question, please. Can you ask your question?
All right. Thank you very much. Good evening, everyone. Thank you, Ma, for this informative and impactful presentation. During the presentation, I was meant to understand that ICF covers psychological aspects of the patient management and also the mental health, also, which is very important when assessing patient. Thank you very much. Thank you very much, Ma, for that clarification and information. I have a question, which is why is it so important for us to use that ICD codes and qualifiers? And when assessing patient, are we also going to use them? Because sometimes you are not the only one to treat that patient. Maybe another physiotherapist will come and treat the patient. So what if that patient is not conversant with that codes? And also, can't we just like write them in form of like narrative formats? So these are my questions. Thank you very much.
That's the reason why all this is. Thank you for that question. That's the reason why all these are being organized. It's expected that after learning it here, you go back there and start teaching others. By the time everybody, even the younger ones that are coming, if you are a lecturer here, you teach your students. If you're a clinician, you teach the ones that are working with you, so that everybody will know it and start using it. Not only, you know, is like when I was talking about the benefits of ICF, he said it is a framework that brings everybody together. It's expected that whatever thing you write, even if you take it to any other place outside the country, the same thing you document it, the person will be able to understand it. So that's why how it's supposed to be. Maybe you are working in maybe neurosurgery, and maybe a physiotherapist in neurosurgery, you assess a patient, maybe patient has a cardiopulmonary condition, invite a cardiopulmonary physiotherapist to come and assist you. It's expected that the person also knows about ICF. I think that's the reason why the board, they are organizing this, so that when you learn it, go back, teach others. Everybody will be on the same page. Everybody will be using it. Like I said when I was presenting, that this thing was adopted or approved by the World Physiotherapy since 2003. And today we are still talking about how to use it. We are backwards, so we need to do something about it. Don't just stop, let it not stop with you. Go back to your clinic, go back to your institution, your lecturer, and start teaching, bringing students up to know this, to learn it, so that they will be able to use this even in their practice. Is very, very necessary. You can't talk about rehabilitation without ICF. You cannot talk about rehabilitation without, because rehabilitation has to do with optimizing function. And ICF also has to do with functional status, both in the assessment, both in the treatment, both in the diagnosis. Thank you so much. I don't know whether that has answered your question. Have I answered you, please? Or should I still throw more light on it?
Ma,
Yes, ma. Yes, ma. I've
Johnny.
gotten it, ma.
Okay.
But ma, I don't know whether if the document can be shared so that we can share it in our departmental platforms. I think it would be best. Thank you.
All right.
Okay, Ma, we have a question in the chat box. Someone said, can you give a clinical illustration of how this ICF can be used in assessments? Your line is breaking. We can't hear you clearly.
Okay, can you hear me now?
Yes, we can, Ma.
Okay, let me use my own area, pediatrics, cardiopulmonary, as an example. Let's say a patient that has empyema thoracic, that is pulse in the pleural area. You want to assess the impairment. Okay, the body structure is the lung. The lung is the body structure. Then which is impaired because there is reduced lung volume. There is restriction there because of the pulse in the pleural cavity. Then the body functioning. Of course, there will be reduced lung volume. So we put it down under body functioning. And when there's reduced lung volume, it can lead to a lung collapse. So remember I said you have to do things, apply things, bring in things that will prevent, because this problem now can lead to activity limitation. Okay, there's a patient I'm managing now that have and that's why I'm using this as an example. Has an 11-year-old child, has empyema thoracic. Okay, it can lead to lung collapse. So what do? You now apply things that will cause the patient, introduce things that will prevent further activity limitation, because this has stopped the patient was not working when we came in, when we were invited. Patient, because of fatigue, there was respiratory distress, there was fatigue, the patient could not walk. That's activity limitation now for this patient. And the patient is in school. And because of the problem, he was admitted in the hospital. So you have to also do things as you're working towards activity to improve the activity of the patient. You also have to work towards participation for the patient. The patient, your goal, another of your goal is that the patient will go back to school. So you begin to build endurance. As the patient is improving, you build endurance. Things you have to do in order to prevent lung collapse, because if there is lung collapse, it will create more problems. You work on the impairment by maybe using a spirometer, incentive spirometer. You use them because as you're assessing, you're also introducing your treatment. Use thoracic expansion exercises, into postural correction, everything. Then under the activities, you can also, as the patient is improving, you introduce aerobic exercises to improve endurance, because if the endurance is not there, it means the patient will not be able to participate, will not be able to play, because the patient was playing before. He has to go back to what he was doing before. You begin to introduce the play. Then you prevent further participation restriction. I don't know whether I've answered you. I don't know whether that has answered your question.
Okay, the question was asked in the chat box, so maybe they can respond to know if the question was answered. Dr. Andrew, we can hear from you, sir. Can we hear from you, sir?
Okay, right. Again, just like Dr. Ohaike said about the use of ICF and rehabilitation, there is no content, or little or no content of rehabilitation in our undergraduate curriculum. A lot of our treatment intervention planning is centered around impairment. Yeah, someone talked about that we use ICF earlier, but when we look at what we call application of the ICF, the only thing we are dealing with actually is more of impairment, because there's no time in our clinic that the occupation of the patient is our priority to plan, or how many times we manage a stroke patient and we follow up to see if they are able to go back to do those things they do before they had this, or what other problem came up post-stroke and we address it. Often what we pay attention to is the weakness, the muscle. One muscle is weak, is weak. So we want to get muscle power, we want to build muscles and all that, or we want to reduce spasticity. And we spend a lot of time managing spasticity. If you put all that under the ICF, you will still realize that everything we are doing, we are not applying the ICF. We are only interested in correction of the impairment. So we have not been doing that. And this is what the RCF training is all about. Our curriculum did not embrace rehabilitation. Now, we want to implement rehabilitation 2030. Many countries are ahead of us. We are just trying to do situation analysis now. This is something we are supposed to have done or to be completed by 2030. We are in 2025. We've got 5 years. And we are just at stage 1, where some countries are at other levels. So the bottom line of what I'm trying to say here is we cannot, just like Dr. Heike said, fit inside rehabilitation mindset as long as we continue to operate within the mindset we are operating from. If we don't change, then the whole essence of this RCF training is defeated, because this is the only thing for now that is helping us to start thinking inside rehabilitation. The curriculum has been changed in our institution to get another opportunity to upgrade our curriculum, to embrace rehabilitation. The registrar is battling with it, with the academicians. It's not easy. However, we cannot continue to operate the way we used to operate and believe until the curriculum in school is changed. However, when the young ones graduate, those of us they meet on ground, are we operating the ICF? Even if they don't learn in this, they need to learn it when they get into practice. But everybody have to implement it. So I will say this, that based on the last question of one of the asked, that what is the benefit of us using the ICF rather than using words? If we have to write in words, then we need to be able to do a lot of descriptive writing. Using the code does not remove descriptive writing, because again, we are not taught descriptive writing. What I mean by descriptive writing is for me to see a stroke patient and to be able to say this patient works with internal rotation, adduction of the lower limbs. I mean, internal rotation, adduction of the upper limbs, or external rotation and all that. So this gives us a pattern of how the patient moves, and maybe in some few weeks, we see a change in that pattern and we can descriptively write again how the pattern have changed. However, using the ICF code help us to know where we are at when we first do the initial assessment. Please remember that assessment under rehabilitation is also your intervention. So there's no time that I'm doing assessment and I'll go and plan intervention. Assessment is intervention. So what do those codes indicate for us? Yes, where do we place our priority? Instead of us writing a lot of empty words, once we use the code, we know where the major issues are. Just like Dr. Ohaike said, so it helps us to know where we focus our intervention. 2, as we progress in the patient's management, the code also will change when you review. If you are managing a patient without a change in code pattern of where there is problem or the problem remains the same, you are not doing the right thing. Without a code, you might just continue treated as above, which is what we do in our clinics most of the time, treated as above. So it helps us to monitor progress. It also helps us to monitor change, because the code will change and you can use this code in collaboration with your outcome measure. So it helps a lot, but we have to learn it. We know it's a challenge right now, because right from our undergraduate years, we are not taught how to do all these things. We just manage our patient. But going forward, whether we are taught or not, the reality is that we can't migrate inside rehabilitation and leave the ICF. The ICF is the whole of rehabilitation is centered around the ICF. Centered around the ICF. And when you use it, you see a lot of things of using the ICF. Because sometimes I've had a situation where a patient will come to my clinic. The patient is working, is doing everything right. And I typically, leaving the teaching hospital, you will say this patient is discharged. But this patient did not feel okay. Even though he has gone back to his place of work and all that. But what brought me is his brother that brought me to my clinic. And when I assess everything, I realized, okay, on the level of impairment, it's not that serious. Activity limitation is not that serious. So where is the problem? Participation, okay, you go to work, you do basic things, but I go deep And I realized one of his major problems is that he doesn't even know which position to assume to be able to meet with his wife, and he just got married when he had his. Two, he has not been able to meet with his wife for up to a year, and that is really depressing him because he felt he just married this lady to punish her because he has stayed away since he had this school. So all these we are not looking at in the clinic when he was discharged from the hospital. Nobody is paying attention that is he able to do basic things he needs to do in his life. But placing it on the impairment, I know, okay, it's not that impaired, right? Participation is trying to do the best he can do. But when you now look at his quality of life, which is the participation restriction, his ability to integrate, then I realize that is where his problem is, and that is what I focus on. How will he be able to meet up with his responsibility with his wife? And this does not require me to start doing my shaka, pull the hand, pull the leg, push. That is not necessary. That's not what he's looking for. This is what we are looking for in our clinic. Push against my hand, push against this, go and carry body blaster. He can carry body blaster for the next 2 hours in the gym. Does that make him meet up with his wife? It's not. And that is his problem. But I will not get to that if I didn't place it on ICA. Right? So please, let's make use of it. Thank you, Dr. Aiken, for the wonderful.
Thank you, sir, for the contribution.
Okay, thank you so much, Ma, for this class, and thank you also, Dr. Andrew, for adding more insights to the class too. So it's already 10 o'clock, but before we go, we'll be taking our quiz for tonight. Is a short one. So I'll just send the link over here. Sorry, I'm on it. Please check the chat box, and that's the link for the class. Remember, it will be taken down anytime soon. So let's answer the question before the link is taken down. So that will be all for tonight. Dr. Andrew, please, sir, do you have anything more to say before we call it a night? Okay. All right. So I think it's no longer on the call. All right, ladies and gentlemen, thank you so much for joining in for today's class. See you next week, Friday. Good night, everyone. Please do well to answer the question. The link is already in the chat box. It will be taken down in 15 minutes. That'll be all for tonight. Thank you so much. Good night.